Neither the El Paso County Medical Society, its members, nor KCUS-TV shall be responsible for the views, opinions, or facts expressed by the panelists on this television program. Please consult your doctor.
There is much cause for optimism in the world of prostate cancer with new research, both current and on the horizon. During this next show, we have experts answering questions about prostate cancer, from screenings to diagnosis and to treatments and then to advanced treatments. Stay with us and think of some questions of your own that you want to ask us this evening. The telephone number is 881-0013. We are also streaming live on Facebook. So if you have a Facebook app, you're able to ask questions live on the Facebook app, and that comes to us as well. This evening's program is underwritten by the Rio Grande Urology, and we also want to thank the Texas Tech Paul L. Foster School of Medicine for providing the medical students with us this evening, and they're the ones that answer the phones and make sure that the questions get to us. We have Aaron Pines here with us this evening, and we also have Heather Jones with us this evening, and this is the beginning of the school year, and they're already starting with their studies. Actually, a lot of them studied throughout the summer too, so thank you very much for being here. I also want to thank the El Paso County Medical Society, who brings the show to you several times a month. I'm Catherine Berg, and you're watching the El Paso Physician. Good evening again. We have a prostate cancer program this evening. It is September, from early diagnosis and treatment to advanced prostate cancer care. And with us this evening, we have three veterans. It's nice when we have friends on the show. We have Dr. Calvin Hahn, who is radiation oncologist, so you're going to get all of the electrical questions. We have Dr. Pan Valilis, who is hematology oncology, so you get a lot of the chemotherapy questions. And then we have Daniel Vogelweed, who is our urologist, and you're going to get all the other questions. Probably a lot of screening too. Screening is always one of the big ones. So it is important. It's very important, and I know it changes a lot through the years. And we were just talking about, prior to us going on air, 22 years ago, my first El Paso Physician show was a prostate cancer show. It's when I was still working at the American Cancer Society. And we were talking about Dr. Horowitz, Dr. Chesbrough, and you. Somewhere along the lines, I feel like you've been somehow involved in the show in every way, shape, or form. So, and my notes go back to 2011. It's kind of nice. I'm going to start off with Dr. Calvin Hahn, because you are on my right. I usually talk about what the prostate is, et cetera, but in the world of prostate cancer, I feel like when we did this show so many years ago, rarely did we have hematology oncology very involved in prostate. It was like in all other cancers, but with prostate, it was mainly radiation. So in your world, all day, every day, how much of what you do relates to prostate cancer compared to other cancers?
In my practice, about 80% of the patient I treat are about prostate, and the rest are the other cancers like breast cancer, lung cancer, rectal cancer.
Okay, and so when we talk about a radiation oncologist, and I want to make sure, and I talk about this every time we have a show, a radiation oncologist is not a radiologist. Very, very different. So when you're looking at, you are medically practiced and licensed in the world of oncology, which is cancer, and you specialize in how you zap the tumors, so to speak. So Correct. I just want to let the audience know that. Dr. Valilis, when we talk about hematology oncology, I know it's kind of one and the same, it's blood. Often we refer to the oncology docs as the chemo docs, and why might that be?
Yes, because sometimes the prostate cancer is advanced and you need systemic treatment rather than local treatment like surgery or radiation. Mm-hmm. So we're responsible for giving chemotherapy or hormonal medications in order to suppress the cancer. So it's not only chemotherapy, we deal also with certain pills that will fight the cancer.
Okay, and hormonal treatment in this particular cancer it's big, and the studies again, and we're going to talk about, as we said before the show, even though we've been doing it so long, this show is going to be very different than it was last September, just on what's happening on the horizon. Dr. Vogelweed, urology. So again, urology is everything, but in the world of prostate cancer, what do you do all day, every day? He chuckles.
Diagnose it and treat it.
Right, and diagnosing it's a whole nother thing, and we're going to get into that too,
Yes.
of all the different screenings. So while I am with Dr. Vogelweed, I'd like to start there. If you could first describe to the audience what the prostate's function is, maybe exactly where it is, what the function is. And I know it seems like an oversimplistic thing to say, but from there we can go into what it is that we're looking for with diagnosis and screening.
Prostate is basically a sex gland, and it sits right in the neck of the bladder. If you can imagine a balloon and the neck of the balloon, and then the long, thin stem as being the urethra, it sits right around the bladder neck.
Okay.
And its main function is to provide nutrients and a means of transport for semen.
Okay. And that's perfectly explained, because I'd like to go now into the DRE, the digital rectal exam, and I know it's not comfortable to speak about. For you guys, it's what you do all day, every day, but with describing where the gland is and with a digital rectal exam, what are you looking for as a doctor when a gentleman goes in and has at least that's part of his screening?
When you do the digital rectal exam, you can feel the back side of the prostate. You
Okay.
can't feel the whole prostate. The purpose of it is to see if there are any irregularities or nodules on the prostate. If there is an irregularity or a nodule, then that warns you that there may be something going on, and you have to do further testing. The other part of testing for prostate cancer is doing the PSA, or prostate-specific
Right.
antigen.
Okay.
A lot of people say, well, if you have that blood test, why do you have to do a rectal exam? And I've never had anybody say, why do you have to do a blood test if I can do a rectal exam?
Right.
And so, but
Yeah.
it's the combination of both
Exactly.
that is best helps you to screen for prostate cancer. And a very important thing about that is people want to know what a normal PSA is. And if you go to the labs, it says normal PSA is between 0 and 4.
Right.
That's not true anymore.
It's not true. See, in
No.
my head, I still have that as being
Yeah.
true. So what is
Now,
that now?
David Crawford came out with a new diagram on how to diagnose and treat it. And they basically said that if your PSA is above 1.5, you should probably be doing additional testing.
Huh.
And that additional
Okay.
testing can be Select MDX, a PHI score, a PCA3, or a 4K score. Those are the 4 tests that you can do. The Select MDX is probably the more accurate of the 4.
Okay.
And if that is suggestive of prostate cancer, then you probably go on to do a biopsy.
Okay.
If it's less than 1.5, you probably don't need to repeat a PSA for 5 years.
Really?
Yes.
Okay. So I feel like I'm going to focus on you for just a little bit, because this is where the years of screening has always been so frustrating. So, is that changed from last year? I know it's changed from 5 years ago, and and there's reasoning behind it too, because there's false positives, and that's what you're trying to avoid, I'm assuming. So in today's world, what are the recommendations that you're giving to patients regarding screenings?
I say that any male who is over the age of 50 should be screened.
Okay. At least have their first.
Their first digital rectal exam and a PSA.
Okay.
If you are a black male, you start at 40. Some people say 45. If you have a family history of prostate cancer, a direct family history, a parent or a brother, it's also a good idea to start screening earlier.
Okay. And I don't know if I want to bring this up because I didn't ask any of you first, because I know that there's genetic testing with a lot of female-related cancers. I don't know if that's something that's happening now in the
Yes.
world. Okay, so I will talk about that later, because I'm kind of curious about that. And that's something too, talk about something changing every show, what's different genetically on, again, you wouldn't want to just go out and have everybody massively get genetic screening, but if your dad did have prostate cancer and it was an onset at the age of 43, then maybe that would be a good time for him to get tested and then see what genes are there. And the reason I'm saying that too, because I don't want to start that panic of people thinking, oh my gosh, I need to be tested for everything. So let's talk about, if we could, and Dr. Hahn, I'll start with you. Let's say that there has been a diagnosis. So somebody has gone to Dr. Vogelweed and prostate did have a couple of nodules. The PSA, let's say, is at a 7. Does that still stay with you in order to refer? and let's look at how the team works here. And I'm looking at you because I always think the radiation oncologist comes first, and then maybe after that, if it's needed in advanced cancers, it might be the oncologist. But Dr. Vogel, we'd say, again, PSA's up higher than 7, and I guess you would do the biopsy at that point, and after that you would have to take it. So I guess let's talk about the biopsy and describe as specifically as you can how a biopsy is done, because I think sometimes it's the fear of the unknown. So if you describe what it is, it's like, okay, at least I know what the biopsy is going to entail, and I'll be okay with that.
Not necessarily, but
it's not fun anyway. But
you know, and this is one of the other things that's been changing over the years. You know, the standard prostate biopsy is 12 biopsies of the prostate. You do that by putting an ultrasound probe in the rectum and using that as a guide. And generally speaking, you take 6 biopsies from the left side of the prostate and 6 from the right side, being in the base, the middle of the gland, and the apex. So you get pretty good coverage. Okay, it's not foolproof.
right,
There's nothing out there that's foolproof. So that means that even if you have a negative biopsy, if you have a high PSA, that patient needs to be followed.
exactly. Okay, so the biopsy is now, you have one of the several biopsies you've taken, and there does show to be cancer cells in there. And then that goes to that whole other question too of scoring. There's the Gleason scores and the staging, and again, I'm staying on you for a while because going forward with treatments, I think we kind of need to know that. And I don't know if we want to give a pretend case study out there. And again, 7, what is a really high PSA score? I mean, let's say that there's...
Generally speaking, they're become more significant after the PSA is above 10.
Okay.
That's not always true, okay?
Okay.
The problem with the PSA is that it's not always an accurate test for telling you how bad your prostate cancer is. You can have a relatively low or even normal PSA and have a pretty bad prostate cancer.
Right.
Generally speaking, though, the higher the PSA, the worse it is. If somebody comes in with a PSA of 100, you're almost guaranteed that they have prostate cancer.
Right.
If it's 1,000, well, forget it. It's all over the place by then. But generally speaking, the Gleason score goes from 6 to 10.
Okay.
Where 10 is the worst and 6 is the least evil.
Okay.
Most people with a small amount of Gleason 6 do not need to be treated. They go into what we call active surveillance.
Right.
Okay, you just watch those patients. There's actually, you can do genomic testing on that tissue to assess the risk. That's even more complicated. But generally speaking, the 6s probably can go a long, long time without treatment or the rest of their lives.
Okay.
Gleason 7s, if you have a very small amount of a Gleason 7, you can probably, and you do genomic testing and they say it's low to lower intermediate risk, you can possibly put them on active surveillance. Anything above that, you're going to start talking about treatment.
So in Gleason scoring, what does the Gleason score mean? Is this the rate of duplication of cells? Is this, what does the Gleason score represent?
What the Gleason score represents is how aggressive the tumor may be.
How aggressive it may be.
May be.
Okay.
And the reason I say that is because some of them, even though they have the same score, are more aggressive than others.
Right.
And we really have no test to tell the difference.
Right. Okay.
But generally speaking, if you have a Gleason score of 7 and above and you have a significant amount of disease, it has to be treated some way.
Right. Okay, so now, Dr. Hahn, I'm going to come to you, and I'm going to make up our case study. This PSA is going to be at 14. I'm going to say this Gleason score is at a 9. The biopsy has already been done, and let's just say that several of the cells that were taken definitely show a presence of a malignancy. So now, Dr. Vogelweed goes to speak to you, I'd imagine, or if there's tumor boards. I remember in the old days we talked a lot about tumor boards. But tell me, should I slow down for a second?
Just a second,
Okay,
yes.
tell me,
Because
yes.
you have to do additional testing before we send them to the radiation oncologist or we send them to the surgeon for surgery. Okay.
Right.
If you have spread of the disease, if it's minimal spread or spread of the lymph nodes, you can probably still treat it with radiation and cure it. But if you already have spread to the bones and you have spread to the lymph nodes, you're not going to cure it with radiation. There's some argument in the literature that may be of some benefit, even under those circumstances, as far as long-term survival is concerned. But if they don't have any evidence of spread in any one of those categories, so you can always send them to him.
Okay.
for further treatment.
Okay. So, yeah, so this is where it gets complicated, right? I remember too that in the day it was like, well, just talk to your healthcare provider. And again, I'm looking at Vocal Week because he's the first guy on the fence here. So where do you come in?
So usually I get the patient from the urologist after the biopsy. And after the biopsy, what we do is we stage the patient. What that means is
So that's where you guys do some staging.
Yeah, so
Okay.
we can do the staging, or urologists can do the staging.
Okay.
And the staging tells us how advanced the disease is.
Okay.
So the staging involve imaging studies, which are bone scan, CAT scan, and then now we have a new test called Aximum test, and that determines whether a patient has cancer in the lymph nodes or in the bones.
Okay.
So if the cancer is in the bones, then that patient is a stage 4 disease, so he becomes, incurable. We can treat him, but we can't
Right.
cure him anymore.
Right.
If the patient has a localized disease, then radiation or surgery can cure the patient. And if the patient has lymph nodes, then radiation can still cure a small percentage of those patients.
And I love the idea that we can use the word cure now. Again, in old days, we were not allowed to say the word cure
Right.
when we were talking about cancer. So I love that. So let's talk about someone now who it's localized just in the prostate, and it's within the prostate. There's no metastasis. What are some options? And there are so many, and I'm sorry to even throw this out there to you. What are maybe some of the most common options of radiation treatment that are being done today on a cancer that is not in an advanced stage within the prostate?
So if we have a patient with localized prostate cancer, we put that patient into 6 different categories. And the categories, before last year, there's only 3 categories. You have a low risk, intermediate risk, and high risk. Now there's 6 categories. So you have a very low risk, favorable intermediate risk, unfavorable intermediate risk, high risk, and then the very high risk. We put them in the risk stratification because the risk stratification tells us what's the likelihood of that patient's continuing to have the prostate cancer that spread and then eventually die from the prostate cancer.
Right.
So the higher the risk group, the higher the likelihood that that cancer is going to spread.
Right.
So we have to treat it more aggressively.
Okay.
So as far as treatment-wise, there's 2 treatments for localized prostate cancer that's curable. One is radiation and one is surgery. And with radiation, we have the external radiation or seed implant. And then with
And
external...
is that the most used these days? I feel like it is, but maybe I'm just hearing about that. The
Yes.
implant, the external. Okay.
So for the radiation patient, external radiation is still the most commonly used form of radiation across the country.
Okay, across the country. And what would be the second, if you had to vote on a second, vote's wrong word, but if you had to say the second most common radiation treatment, again, localized cancer, what would that be?
So the second most common form of treatment would be what we call seed implant.
Okay.
Or brachytherapy. So
Okay.
brachytherapy, you can actually put the radioactive seeds, or you can treat it using a strand that has radioactive isotope.
Okay. So the external beam is not really something that's used so much anymore.
It's still used for localized prostate cancer.
Okay.
But what we're doing more now is that when the patient has like favorable intermediate risk, high risk, or very high risk, we try to use combination
Okay.
of treatment to be more aggressive
Right.
to improve the cure rate.
Nicely said. Okay, Dr. Valilis, now I'm bringing you in. I'm bringing you into, I'm just going to pretend you're a surgeon as well. You okay with that? For the sake of the show?
Actually, I wanted to say something about
Yes,
that.
please,
Because we have to be clear to our viewers.
Yes.
So the 2 treatment options for the early stage prostate cancer is radiation and surgery. We have to say all the randomized trials have showed that the surgery is superior to radiation. But that's where the patient's preference comes.
Right.
So sometimes when they listen the side effects of surgery versus the side effects of radiation, they will say, okay, I go with radiation. But we have to mention that there are now trials that have collected data for 30 years, and they show the best survival data is with surgery. And actually, I want to ask Dr. Vogelweid to comment on that.
Well, then let's do that. What I was trying to do is not skip you,
No?
because I know Dr. Vogelweid's a surgeon. So let's talk about surgery, and is there ever a time when part of the prostate is taken out, or is it always all of the prostate? And I'm embarrassed that I don't know the answer to that.
Well, and it's good that you don't know the answer, because they're doing a lot of research on that.
Okay.
They're doing research on doing either localized treatment, or they're doing research on doing partial prostatectomies. The problem is that prostate cancer tends to be multifocal.
Yeah.
And
Okay.
so the cure rate's going to be not as good as taking out the entire prostate. The other thing that you have to take in consideration is the age and the general health of the patient. If the patient is going to live less than 10 years, he's not really a candidate for surgery. So your average patient is, if he's 75 years of age, the average survival of a male is 77, or the lifespan of a male is 77. So he's probably not going to be somebody that you send for surgery. If you have a 72 or 73-year-old that comes in and he's in real good health and exercises every day and he looks like he's going to last another 10 years, you can still say, well, let's go ahead and operate on him. And yeah, statistically speaking, if you go hand to hand and you go long-term survival, it's about the same for the first 10 years.
Okay.
After 10 years, it gets a little bit better for people that have surgery compared to radiation. So obviously, if you're a younger person, that's the way to go, is surgery.
Right. Now, here's the question that nobody really wants to know. Actually, everybody wants to know, but it's just not fun to talk about as a doctor. So, and Dr. Valilis, you're right, and I'm 52, so there's a lot of people that I know that have been diagnosed with prostate cancer. What do? Well, surgery, then it comes with A, B, and C, but if I just do radiation. Let's talk about what the side effects of surgeries are, the good, the bad, and the ugly. But the good, we can focus on the good too. But in general, when people are asking you questions, when patients are asking you questions, okay, Dr. Vogelweid, we can do surgery and I will have my entire prostate taken out, let's make it that situation. What could be some of the side effects? And then later he'll talk to Dr. Hahn, and again, it could be a great combination of the both and maybe even the three together, and maybe hormone therapy will come in, and Dr. Valilis, I'll talk to you about that later.
When I diagnose prostate cancer, the two things that you tell patients, I mean, yes, you can have complications to surgery, and you can, that's at the time that you decide for surgery, but the two things you talk about are impotence and incontinence, okay? You can get impotence and incontinence with both forms of treatment, just at different percentage points. Approximately 50% of the people who undergo external beam radiation, not necessarily immediately, but long-term, have problems with impotence. And correct me if I'm wrong, Calvin, but I think less than 5% have problems with incontinence. As far as surgery is concerned, what I usually tell my patients is that if you preserve or spare the nerves that go around the prostate to the penis, your chances of recovering erections after surgery is about up to 70%. If you don't spare the nerves, you're going to be totally impotent. Of course, there are things you can do for that, which I'm sure you know.
Yeah, and that's something too, and I want to be very open and specific on the program too, because I think this is the place to do it, and this is where people can call in and ask these questions. And when we're talking about the nerves, because that's the money spot, right?
I apologize.
Don't apologize. Okay. This is what it's about. You guys are the experts. Tell me.
The incontinence.
Yes.
Okay, incontinence rate is higher in surgery. Most people that have surgery, initially after surgery, are incontinent.
Most people that have surgery, initially?
Initially.
Okay.
But over a period of time, 6 months to a year, about 70% recover their control completely.
So tell me how that works. Are the nerves relearning?
It's a combination of nerves, it's a combination of reconstruction, it's a combination of scar tissue.
Okay.
And it's a combination of the tissue going back to the softness that it had before the surgery.
Okay.
Because tissue initially becomes very firm, scarry, and then it softens up over time. So multiple factors, but it's just statistic. I can't tell you exactly why.
Right, yeah.
Okay, but
And in my head, and pardon me for asking this, in my head I'm thinking that's not something that you can have physical therapy for, and that's why I was asking what is it, but you can.
Yes.
So talk about that.
Okay, let me just, about the other, we still have a 30% to talk about.
Okay.
About 20 to 25% have what we call, now I'm even thinking of the term, the stress incontinence, where they leak when they cough or sneeze or do heavy lifting. And there's a spectrum of that too, so very little to where they may wear a little pad. And most of them are in that category when they leak, to a lot. And then less than 5% are totally incontinent.
Okay.
Okay.
Gotcha. Less than 5%.
Yes.
Okay. And I'm just thinking with a female, if you have a baby, you've got that issue going on. Thank you for laughing. Appreciate that. I need a little bit of humor on the show. So when we were talking about physical therapy on just getting things not back to normal, but getting things working a little bit better, what kind of physical therapy are we talking about?
Pelvic floor strengthening exercises.
Okay.
I usually send those patients to a physical therapist, and it's basically the same exercises they teach women.
The Kegels.
It's not just Kegels,
Yeah.
though. It's strengthening the entire pelvic floor.
And I remember us talking about this on one of the shows. And again, I like to be as specific as possible on the program. So if you are visualizing, a patient is visualizing what you're doing in your body to strengthen the pelvic floor. Because like a woman, they will say, at a stoplight, just pretend like you have to urinate and you just hold things really tight for a while so nothing leaks and you let it go. And so those are Kegels. And to describe what a Kegel is different than just saying, go do Kegels, because if you don't know what the description is, so how aside from Kegels, or what we would describe as Kegels for a man, how do you also do a strengthening of the pelvic floor?
Pretty much the same way you described it. You
Okay.
can tell them, one way I tell them is, go to the bathroom and stop your stream. And then I say, stop your stream for as long as you can stop it. Hold that muscle tight for as long as you can hold it, and then let it go.
Okay.
And do that 10 times.
Right.
And do that routine 10 times a day. And it's just like building up this muscle right
Exactly.
here. Okay. I'm not going to do it from one day to the next. You got to work at it, and you have to keep at it. And frequently you have to stay at it. It's just
Right.
like, you go to the gym and you build up your muscles. You want, if you want to keep them built up, you have to keep on going to the gym.
Exactly. No, I think it's beautiful that you explained that. Dr. Valilis, I would like to talk a little bit about hormonal therapy in the world of prostate cancer. Because I feel like at the end of the show, we'll talk a little bit more about really advanced cancers, and that's where we talk about systemic issues too. And hormonal therapy, I guess, could be systemic.
Yes, because it affects all over the body.
Yeah, so if you could describe to the audience what hormonal therapy is in this situation.
Yes. Prostate cancer is a hormone-sensitive disease in the beginning, which means because this cancer is being driven by the testosterone, the focus of the hormonal therapy is to suppress the testosterone, because the testosterone is the one that feeds the cancer. So at least in the beginning, and when I'm saying in the beginning could be several years, the cancer is sensitive to anti-testosterone medications.
Okay.
So if the patient comes in with prostate cancer all over the body, that will be the first treatment, give some hormone to suppress that. Or if somebody is getting radiation treatment, and we feel that we would like to control the disease even outside the prostate, we give hormonal treatment for 2 to 3 years, and these are some injections.
Okay.
Every 3 months, every 6 months.
Okay.
And that's how we control the cancer, and we bring the PSA down. After a while, the prostate cancer becomes more aggressive, and it's not responding only to hormones.
I see.
And that's
Okay.
when we have to add other medications.
Okay.
So, for example, when the patient in the beginning has surgery or radiation, we continue to follow this patient. How? With PSA. And when the PSA goes up, this is a sign that the cancer is growing.
Gotcha.
But if the PSA goes like 20, 30, 50, this person might still not have any metastasis in the lymph nodes or in the bones. So we do imaging studies, CT scan, bone scan, and in that case, we call that biochemical progression, which means, yes, there are cancer cells in the body that are multiplying, but they have not attacked yet the bones or the lymph nodes.
Okay.
So this particular stage of the disease is called rising PSA. and creates a lot of anxiety to the patient because they come each and every visit and say, I feel good, but why my PSA going up?
Exactly, right.
And then jumping a little forward to complete the issue, the last stage of the prostate cancer, the so-called castrate resistant or hormone resistant, which means just a hormone is not enough, and then you have to add other treatments.
Okay. And when we're talking about other treatments, this to me, prostate cancer to me is the most options of treatment cancer that are out there. And I applaud all three of you and the teams that you work with as well, because there are so many decisions to make when you're a man in the family too of how things go. I've got quite a questions here from the audience, but what I want to do first is talk a little bit about chemotherapy, and that way I can go, that way at least we've covered all of the treatments. And let's now say that there's someone who really has an advanced stage of cancer, and let's say he's young, let's say he's 70 or 65, let's say he's 65, but it's metastasized, and you can tell me where the most common areas of the body that metastasis would be. And now we're looking at, he's already had surgery, he's done radiation, or whatever the format is, he's also done hormonal therapy. Now we probably have to do systemic chemotherapy, and just throw out there what that could be.
Up to 3-4 years ago, systemic chemotherapy was for the patient who has painful lesions in the bones. And
only in the bones?
Maybe
or
in the lymph nodes, but
okay.
The best usage of chemotherapy was when you have painful lesions in the bones.
Okay.
However, over the past 5 years, there is a lot of research that they've tried the chemotherapy medications even in the beginning, after surgery, if the patient has a Gleason score of 10. So in the beginning, you tell the patient chemotherapy will benefit you because your cancer is really bad. And nowadays, we use the chemotherapy earlier than before. But this is based on research, and the chemotherapy has shown to prolong your survival when you are in this terminal stage. So there are 2-3 different chemotherapy medications with the usual side effects: nausea, vomiting, loss of hair, blood going down. And some patients, even in the 85s and even 90s, they can tolerate the chemotherapy if they're in a good shape. There is also another type of treatment, which is like a radiopharmaceutical, and Dr. Han has a lot of experience, that you give a medication in your vein, which is again systemic treatment, goes all over the body, and it is very, very helpful in the bones. So I think we have this treatment here in El Paso, and Dr. Han is doing that.
Yeah, I'd love to hear it. Let's hear a little bit about it, because bones, to me, I feel like once it gets to the bones, ouch. Let's talk about that, Dr.
So once the cancer spreads to the bone, one of the symptoms the patient has is bone pain. And there's a new treatment called Xofigo, which is a conjugated protein with the radium-223 attached to the protein. So what the protein does, it goes after the prostate cells. So it attaches to the surface of the prostate cell, and then in the back of it, you have the little radium-223, which is emitting an alpha particle. So what the alpha particle does, it hits the cells, and then it breaks the cell apart. So once the protein latches onto the prostate cancer cell, the closest cell is the prostate cancer. So the prostate cancer gets bombarded by the alpha cells, alpha particles. So the cells breaks apart. And
how does it know? This is a silly question. I feel like a little kid asking this. How does it know which one the prostate cancer cell is compared to all the other cells in there?
So the conjugated protein is specifically target to the surface of the prostate cancer.
But there's a reason for that.
Yes, tell me.
Calcium is in the same column as radium-223 in the periodic table of elements. And so when the bone is being eaten up by the cancer cells and the bone tries to regenerate, it'll pick up this radium just as it picks up calcium.
Gotcha.
And when it picks it up to try to rebuild it, it's right next to that cancer cell. And it's the alpha particles are what destroy those cancer cells. And it has a very small penetration, only 2 or 3 millimeters, Calvin?
Yeah, the range of the alpha particle is very small, so it doesn't damage the the bone marrow, which is the cells that makes the red cell,
Right, that's
the
stuff that
white
you
cells,
need.
and the
Right.
platelets.
Right.
So it
Jeez.
has very little side effects.
Okay.
And then there was one study, which is what we call the randomized studies, that shows that patient that has a castrate-resistant metastatic prostate cancer, that's
And when you say that, that's hormone resistant, correct?
hormone resistant.
Okay.
Yeah.
All right.
That's has multiple bone metastases, and if the patient doesn't have what we call visceral metastasis, which is organ metastasis, then these patients do live longer with Xofigo, and then a lot of the patients also get pain relief from the treatment.
Right. As bone cancer, yeah, anyway, I don't even want to go into that. Questions here from the audience. One, and I apologize if I didn't say this earlier, so a PSA test is a prosthetic specific antigen, and that is a blood test. So we did have a question about what that was. So a PSA test, I call it a simple blood test, but it kind of is a simple blood test. You can kind of get the score from there. That in association with a rectal exam, and so from there is where the screening comes in, and then
Correct.
from there you kind of look at the two and associate. I know we talked a little bit about it before, but it was one of the questions here to clarify that from the audience. Question here from the audience: does trimming, and I'm reading this cold, so Dr. Vogelweed, this will go to you. Does trimming the prostate around the urethra to reduce obstruction cause incontinence? Does it mess with nerves or cause any erectile dysfunction? A very specific question here from the audience. So, do you want me to read it again? Or?
No, I got
it.
it.
Okay.
Transurethral resection of the prostate is what they're talking about, or TURP.
Okay.
Yeah, that's rarely used for prostate cancer, but it's very rare for it to cause incontinence. If you have incontinence, it's probably either because the external muscle is damaged or because they already have. Somebody already has some kind of a neurological problem that can cause incontinence. Impotence occurs in about 3% of the cases, and that happens theoretically because when you do the resection, you do it with electricity. And if you get close to where the nerve's at, it can damage the nerves with the current, the electrical current. But that's also unusual.
And in surgeries now, is this a robotic surgery that is used now more
The
often?
the most common way of doing a radical prostatectomy is robotically.
Okay. If you don't mind, take a couple of minutes just to describe what that is. Most people have heard about it, but some haven't. Because I think about how specific, and I remember on the show many years ago, we looked at one of the tweezers of the robotic arm and the cutting of the stitches compared to a surgeon's fingers, and they were like meat fingers, and this little tiny beautiful part of the robotic system. And so there are some people that are still a little bit uncomfortable with it, but I think it's the most beautiful thing invented ever. But if you can talk a little bit about the surgery of a robotic system compared to even 20 years ago.
Oh, geez.
When we didn't have it. Yeah, oh
Yeah, we
geez, look
didn't
at that.
have-
Oh geez.
Yeah. Well, I
Completely
mean, number
different.
one, robotic surgery is laparoscopic surgery. It's done with small little cuts. The biggest cut you have is maybe 1.5 inches long, 2 inches long, to take the prostate out at the end of the procedure. But on the average, usually you have 5 or 6 cuts. And through those cuts, one is a camera, and then the arms of the robot. And there are usually 3 arms of the robot. And then there's also a working port, because you have to put stitches in and bring them out. The robot does not do that. And yeah, it has 2 little small things. In one hand you have scissors, and the other one you have little graspers. And that's how you do your dissection. Okay, it's a really neat procedure. It is recovery is much quicker. If you ask, your chances of sparing the nerves are probably much better. Your chances of incontinence probably are pretty equivalent. But
When you guys come back, I'd love, because I know there's a one time we showed a video on how that works. So you're operating everything. I mean, you're in there,
Yes.
you're physically operating.
you're actually sitting in a console. It's sort of like playing a video game.
Right.
The robot arms are next to the patient and placed in the patient. Then you go over and you sit down in a console and you run the robot from that console. You're no
It's
longer
fascinating.
scrubbed in. You have an assistant that's scrubbed in, hands the instruments to make sure that everything is, or basically sutures or whatever you need. And you sit there from the beginning to the end of the operation. Of course, you start out by making the small access ports,
Right.
and then at the end you have to close them up.
Exactly. And I'm just thinking too, sutures inside of the body too. If you know, when you have to do that, how tiny and how precise you can be with that. I just remember
the actual robotic arm has better movement than your wrist does.
Nice. Beautifully said. Beautifully said. What I'd like to do is stop questions here from the audience for just a little bit because we have so much to cover. And Dr. Hahn, I'd like to start with you because I feel like the world of radiology is what's changing the fastest, is what, you know, there's research out there, we're doing this now, we're doing that, and this is working better. What, in your opinion and your colleagues' opinion, has been the most significant changes in the world of radiation and prostate cancer over, let's say, the last 4 or 5 years? If we have a lot going on in this last year, but at least it gives you a little bit of a bigger window to work with.
Right. So, I would say the last 5 years would be IMRT.
Okay.
Intensity modulated radiation therapy, which is now the most common form of radiation treatment across the country. Because IMRT can be done with the LINAC, which is a machine that we use to treat many types of malignancies. There's other form of radiation treatment like proton beam, cyberknife, tomotherapy, but they're very specific in terms of these machines. Like cyberknife is used for radiosurgery, and it's very expensive in terms of the costs, and it's mainly dedicated for treating high doses with these machines. So many other places, if there's not enough patient population to support
To justify that,
the machine, then you can't justify buying it. So at least in El Paso, we don't have cyberknife. Even in New Mexico, we don't have cyberknife. We do have IMRT, which is same kind of treatment that a patient will get if they go to Mayo, Scottsdale, or UCLA.
Right.
And we don't have proton beam. Proton beam is very, very expensive. The machine itself costs over $50 million, and our machine costs around $3 million. So it's a huge cost, and then you need a very you need a large group of physicists and dosimetrists and therapists to support these treatments. So mainly across the country, IMRT is the most
is
common
the standard.
form.
And for proton beam, where would that be in the closest proximity of El Paso for proton beam?
So here, MD Anderson has
Okay.
it, and then Mayo, Scottsdale just started their proton program.
Okay. And it's amazing to me too. God, again, it's so full. It's amazing to me how radiation is so supported now. And Dr. Valilis, I'm going to go back to you. Something that we may not have really spoken about tonight. There's chemotherapy now where radiation seeds are very specific to a very specific place. And there's now a type of chemotherapy, or different types of chemotherapy, where, if I understand it correctly, we were talking about systemic earlier, but chemotherapy that's also can be very localized. Am I making sense when I say that?
For the prostate, no.
Not for the prostate.
Like
okay.
say for liver cancer,
Okay.
yes.
Okay.
If you have liver spots, there is chemotherapy that can go inside the liver, localized chemotherapy.
Okay.
But prostate cancer, we're talking about when the cancer is already spread to many parts of the body.
Okay.
So you give a medication in the vein in order to attack the cancer in all those spots. So let's say the medication that is most commonly used, the so-called Taxotere or
Yes.
docetaxel,
Okay.
was approved by the FDA because not only improves the quality of life of the patient, but also prolongs the life. It's a pretty strong medication. FDA has approved it for 10 cycles. But most of the patients, after 5 or 6 cycles, they feel so tired. They have tingling and numbness in the fingers and in the toes, problem with the balance. So
And a
we don't
cycle
go.
usually is how? Is it
Every
like
3
once
weeks.
every 3
Once
weeks?
every 3 weeks.
Once every 3 weeks.
So
okay.
we always talk to the patient and evaluate the patient. Apart from the guidelines, we take the patient's preferences and to make sure that this is something well tolerated before we proceed.
Okay.
Another good thing about this medication is if your cancer is in remission for a couple of years, and then after that we can use it again. So there are some options to prolong somebody's life.
Okay.
If you ask me the same question that you asked Dr. Han, what is the best thing in systemic treatment over the past few years? It's in the stage that's called rising PSA. For
yeah,
example,
you talked about that earlier. Okay,
yes.
good.
So
yeah.
what is rising PSA? Somebody had already surgery or radiation, and then after 1 year, 2 years, the PSA goes up. So we're doing tests to find the cancer. We don't find the cancer anywhere, and we used to keep monitoring the patient. Now FDA has approved a medication that delays the appearance of bone metastasis. So you tell the patient, although you don't have any bone metastasis, you will
Right.
get them for soon. We can
So
give
you
you
don't
a
have
pill.
them yet, but high chances are you're getting them soon.
100%.
100% you're going to get
Yes,
them.
rising PSA means the cancer is growing, but it's growing.
Okay.
So there is a medication to tell them it's a pill. You take this pill, and the moment that you develop bone metastasis is later. 1 year later, a year and a half later. So some of the patients say, okay, I like to try this medication. So this is the latest in our field. And the other thing that you touched briefly before is the genetic testing. So right now, it's practical to do genetic testing to patients who have family history, especially a brother or a father. However, there are some groups like geneticists, molecular biologists that say we should test everybody for genetic mutations. So this is available in El Paso. We have a specialist in our group, Texas Oncology, that does this job. So we try to refer the patients.
Is that becoming more and more common
More and
now?
more
It
common,
is.
yes.
It is.
Yes.
Okay.
And usually if a patient sees a genetic specialist, the insurance will approve the test.
Okay.
But if they see like a general physician, insurance might deny.
See, that's my big question.
Yes.
And years ago we were talking about that too, because even though it's not part of medicine, insurance is a huge part of what is reality
Yes.
to this world.
Yes.
So when we're looking now at being able to justify having genetic testing, are there, and you may not know, and if so, I apologize for asking, but are there certain criteria that can justify to an insurance company?
Yes.
And so what might those criteria be?
What I told you before, the family
brother,
history,
the
if you're
direct
African
descendant.
American, the
Okay.
incidence is higher. So these things will, go through the insurance. Other things are still coming,
Right.
emerging. As long as the research is going on and the data shows, yes, we find hereditary cancer even in people without any risk factor, then pretty soon the insurance become covering that.
Okay.
Yes.
And it behooves the insurance, because if you catch
Yes.
it early, it's less that they have to
Exactly.
pay out of pocket
Yes.
too. Dr. Vogelweed, I know that we were talking about something earlier and you kind of raised your hand a little
Well,
bit, but you had something to add.
Well, I need to tell you a couple of things.
Okay.
One, now urologists throughout the country are tending to form groups. And within those groups, they're tending to pick a physician who's going to run what we call an advanced prostate cancer clinic. I'm the guy in my group.
Okay.
Okay.
Uh-huh.
What he just said is absolutely true. But if you have, what he was talking about is when your PSA starts writing, that's called M0 disease. M means metastases.
Okay.
If there's no metastases, okay, then you
Right.
don't have a justification for treatment.
Gotcha.
But there are now 3 drugs. The last one that was approved was just approved last week. The first one was approved was enzalutamide. No, excuse me, apalutamide. The second one was approved was enzalutamide, and now it's darolutamide. These are 3 medications that have been approved. But before you can go to those medications,
Right.
you have to have had the shot.
Okay.
If the
Right,
shot,
right.
has been given, and then your PSA starts rising, then you can start going to what these are called oral oncolytics, approved for M0 disease.
So the approval process happens how? Once you have the advanced prostate cancer and the approval process for one of these 3 medications, how does that work? I mean,
Well, you have to.
I know it's a loaded question too, because
No. I mean, it's a very valid question because sometimes it's very difficult. Insurance companies sometimes do not approve it. They just don't want to. Medicare, generally speaking, does approve it, but it depends on whether it's been, FDA approved and they've gone through whatever it is to be able to allow it to give the medication. They are very expensive, and that's the main reason why they don't want to
Right.
approve them.
Right.
Okay, but on top of that, we also have foundations where we can get money, and we frequently, use foundation money if we can't get out some other kind of coverage. It's very complicated, and so I won't get into that. But the other thing that's also important is that before you get to chemotherapy, okay, you can do the oral oncolytics even when you do have advanced disease. Okay, you can do the radiation, the radium-223, and we also have immunotherapy.
We haven't even talked about that, have we?
And
Right.
this is in this. I mean, I don't want to get this confused with what Dr. Villalobos can tell you about some of the other forms of oral medications that are used to block the growth of the prostate cancer. But immunotherapy is the treatment is called Sipuleucel T, or Provenge, and that's where you actually take the blood cells, or the white blood cells from the patient, and you send them off, and they treat them, and they sensitize them to an antigen, and then that same blood is brought back and given, or the serum is brought back and given to the patient.
So expand on that. 'Cause that fascinates me. Just the idea that you can do that. So when you're talking about the cells, how as the surgeon, what is that process? What are you doing with the patient on the operating table, and how are you sending it? If you can walk
It's not
through,
done on the operating. You send them to the blood bank.
you send them to the
And
blood bank.
they do plasmapheresis, basically. They filter these cells from the plasma. It's about a 4-hour process.
Okay.
And then it immediately gets sent to Atlanta. And in Atlanta, they expose it to the antigen, and it's basically prostate-specific antigen. No, it's not that. But anyway,
Another antigen, but
yes, another antigen.
Yeah.
And then it's incubated. And then so the cells adapt to that, and then it's sent back and then infused in the patient, and that teaches the patient's blood cells to fight the cancer.
Do you see that being and I know this is a prostate cancer show, but I feel like, and Dr. Villalobos, you're smiling. You look like a little boy right now.
Yes, no, I'd like to add something.
I would love for you to add something, because
The
I
idea
see this
is
to be in the
wonderful.
future.
The idea is wonderful, and it's very good. That fascinates you. What's the result? It prolongs your life for 4 months, and the cost is $120,000.
Oh my goodness.
So it has fallen off popularity. 5-6 years ago, we'd use more because we didn't have any other option. But now, when you tell the patient, that's it, says, for life, 4 months, and I have to go through this process to the blood bank. They poke me twice, so that's the result. 4 months for $120,000. So sometimes we have to think about the cost, what we do.
Do we
Also,
see
the initial studies that were done that showed 4-month survival were studies on people who already had significant advanced disease and
Treatments,
had already
yes.
had chemotherapy.
Yes.
Okay. And
And
there's,
this is where 5 years from now we could be talking about the same subject and it'd be flip-flopped.
yeah. Well, there's nothing, the problem is there's nothing that's going to cure it.
Right.
The whole purpose, from the time it becomes metastatic on, is to give the patient more time and give them quality time, okay?
Right.
And for me, I give them a sequence of things, okay? One of which is immunotherapy, plus the oral oncolytics, and they're doing research on that. Now, they're even doing combinations of oral oncolytics with other medications to see if they can prolong survival that way. And then the last thing that you do is, if nothing else works, is chemotherapy.
Right. Right.
And but it's and every single day they're coming out with new studies, new tests. I can't see a cure in the immediate future, but if you can give somebody, time for their kid to graduate from high school,
Right,
or to see their kid, or see them get married, or you can give them 2 or 3 or 4 more years. You
That
couldn't
quality
do
of
that
life
before.
matters, yeah.
Once you had significant metastatic disease and they didn't respond to the shots anymore, they only had about a year and a half survival, statistically speaking. So if you can give them 3 or 4 or 5 years, and use in the combination, you don't just look at it as one thing. You look at, we're going to give them this, we're going to try this, and we're going to try this.
Right. Right. I'd like to, we've got about 4-ish minutes for the show before it ends, and I want to end on a very positive note in the idea of active surveillance. We talked a little bit about that earlier. So let's take ourselves back to the very beginning of the show when we talked about watchful waiting is what we used to call it, but there's PSA levels, it's not really high, no need for a biopsy yet. When is it, and I'm going to look at Dr. Vogelweed first, when is it that the active surveillance is okay, and when does that change to, okay, we've got to do something? And I know we don't have a lot of time to talk about it, but I'd like to know, because that's a huge active point. You sit, you wait, you watch, how often you go in, once every 6 months, once a year, etc.
Okay. The things that you watch, obviously, the PSA, okay? Once you've made the diagnosis, if you decide to do active surveillance, and we already went over that as to what, okay, then you continue to follow the PSAs, and usually it's recommended that you repeat the biopsies in a year.
Okay.
Okay.
So a year, so it's not 6 months. It's
No,
a
you repeat a biopsy in a year.
Okay.
A year to year and a half is
Okay.
standard, okay? If a year and a half you haven't had a significant change in the PSA, and a repeat biopsy, sometimes those come back negative, okay? If it is still low, well then you just continue to follow them, and then you decide when to biopsy them again, depending on basically how they're doing and what their PSA is doing.
Right.
Now,
Okay.
when do you treat them? You treat them when, if you come back and do a biopsy and they have a higher stage, okay? Instead of a 6, they have a 7.
Right.
Or
And
if
the
they
PSA is also risen.
Yeah, and the PSA is right. Or if
Okay.
they have more positive biopsies. But you can have the same PSA and have more cancer.
You talked about that earlier too.
Yeah, so
Right.
you have to be careful with that too. That's why it's always recommended at a year, even if nothing's changed, repeat your
Right.
biopsies.
Okay. And I like the way we talked about that because I don't know if it was you, Dr. Chesbrough, or Dr. Horowitz, but someone said a long time ago that if you live to be 100, every single man's going to have prostate cancer. And so I'm talking about this active surveillance not to scare people, but that it is an option that you can just watch what's going on, but make it active, because I think sometimes that word is being out there and it's like, oh, I just have to watch it, which means there's no problem. But no, there is. You need to make sure you get checked. I want to say thank you so much again to everyone on the floor. We've had Dr. Hahn, Dr. Valilis, Dr. Vogelweed, and I want to say thanks again to Aaron Pines and Heather Jones, our medical students from the Texas Tech Paul L. Foster School of Medicine, for being here. And you can watch the show again on kcostv.org. Also, you can watch it again on the El Paso County Medical Society site, and that is EPMS.com. And if you are a Facebook person, you can watch this again in the next hour or 2 hours. So when you get home, not now, when you get home, you can watch it again. But thank you so much for your questions. I want to say thank you to Rio Grande Urology and to El Paso County Medical Society. I'm Catherine Berg, and you've been watching the El Paso Physician. Good night.